Today on Midlife Conversations, I've got Dr. Salas Whalen, who I've been following on social media. She's triple board certified internal medicine, endocrinology, and obesity medicine. And what got my attention about her social media was talking about the trendy drug right now, Ozempic, the thing that everyone's accusing people that have lost weight of being on, the thing that's also been helping a lot of people. I have so many questions. I am completely clueless when it comes to this medication. So thank you so much for being here today.
Thank you for inviting me.
Okay, so first and foremost, we know this is a trendy topic right now, but how did this even become part of your practice? When did you make this shift to going, I need to include this in my practice? I know you've been dealing with obesity for years and years and years.
So when I finished my fellowship in endocrinology, a new drug got approved was named Byetta in 2005, and it was the first in this class of drugs that were so popular right now. They're GLP-1s, like the class of the drugs they're called incretins.
Hmm. Hmm.
And in 2005, when the first one was approved, it was with the indication for type 2 diabetes. And being an endocrinologist, that's my bread and butter in endocrinology is type 2 diabetes. And I started using that drug then, and then eventually a newer one, which was Victoza in 2010. And while I was using it in my patients for diabetes, it was really interesting. Patients were coming back not just with better glucose control, but with weight loss. And that is something very rare that we didn't see in any diabetes medications. Either we got the glucose control, but we never saw weight loss with it, right? We had to tackle the two things differently and separately. And for the first time, we had a drug that it was tackling both things in one drug. So eventually I started using it off label in my patients for weight loss. And then the indication came for weight loss in 2012, and then the rest is history, right? But really, I've been using these drugs for since the beginning that they started.
Got it. Okay, so you've seen this whole like evolution of this. Now, where did it become? So when you see somebody that's got obesity dealing with this, how do you go from let's try you on let's just change your habits with nutrition, with workouts, with all of these things. Let's try supplements to these drugs, and then to the extreme where some people actually have weight loss surgery. How do you decide like who's ready for something like that? And I know there's a huge stigma around obesity, especially in the United States, my gosh, of people just saying, oh, it's because they're not doing these things or they're not working hard enough. So how do you know, like, how do you navigate that and know when it's time for those things?
So we have guidelines on when and who to use these drugs, right? So the current guidelines, the current clinical guidelines by the Obesity Society, the Obesity Medical Association, the Endocrine Society, is a BMI of 27 plus one comorbidity, which could be high blood pressure, high cholesterol, prediabetes, osteoarthritis, sleep apnea. Then they made the qualification for being prescribed weight loss medication, or a BMI equal or greater to 30 without any comorbidity. Then they meet the criteria for weight loss medications. Now, definitely what I practice in my office, I stick with the guidelines for sure, but I also do the BMI is not the best tool or the tool that we should be using to classify on somebody needing or not this medication, right? The BMI is a very antiquated, simple
Yeah, I was going to
calculation.
ask you about that because sometimes, like I know with people that have less than 20 pounds lose, I'm like, this isn't even an indicator because you could have more muscle, you could have this. So I was going to ask you about that.
So I really don't go by the BMI. I go more, I do body composition in my office, right? I measure visceral fat, I measure percentage body fat, I measure muscle mass. And according to that, I make my recommendations. And it's not just to start the medication, but also to guide me in the goals of the patient, right? I tailor their goals according to their metabolic internal numbers, not the BMI or the number in the scale.
Got it. And then do you take lifestyle habits into consideration? Like I would assume, I mean, I'm guessing you're the doctor, not me, but if somebody comes in and if it's very different if they've been working really hard on what they're eating and moving and they've been doing all these things and they're not moving the needle because they've got this genetic markers or whatever it is. And then there's somebody that really hasn't even attempted to do that. Do you start them first on a healthy eating plan? What do you do?
Well, I have to say that unfortunately for many of my patients, I'm their last stop, right? When they come to me, they've done everything. I hear of diets that I've never heard in my life from patients, right? That they've done. I mean, some patients have struggled with weight for decades since childhood. So I have patients that told me I had my first trainer at age 12. I went into my first diet at 9. I went to a fat camp at 12. So the patients have done the legwork, right? I mean, I haven't had a patient cross my door of my office that is not exercising, that is not knows what should be eating, that has not tried the
Yeah.
trainer, the extreme caloric restriction, the extreme workouts, right? The fasting, the cleanses. I have not met a patient
Yeah.
with obesity that hasn't done some sort of work,
No,
right?
when you look at obese, when you say obesity, is there do you define a certain amount as being that? Because I think like there's such a range, right? There's the
Yeah.
women that have a few hundred pounds like extra, and then there's a few that they're calling themselves obese that have 20 pounds to lose. So how do you even decide what is and what isn't?
Again, from their internal numbers, right? I mean, the general, I think, view or the general consensus is using the BMI, right? But thankfully, the American Medical Association came last year saying that the BMI should not be the tool to diagnose somebody with overweight or obesity, right? So I base more my numbers in their percentage body fat, in their visceral fat, and in their muscle mass. And then from there, I categorize the patient, right? And where do they fit?
Now, when I would work with people that have an excessive amount to lose. I've had experience with some of them that came to me that did surgeries. You know, they had the sleeve, they had us an actual surgery. And when that happened, they would lose their teeth. You would see their hair change. Like they had a lot of horrible side effects from that. And it's like they were presenting as malnourished after. Is that similar stuff happen when somebody jumps to a medication? And why does that happen with weight loss surgery?
So I think, unfortunately, it is a risk, but I say this so many times and I will never get tired of saying it. The efficacy and the safety of the drug is going to depend on the expertise on who's giving this medication. Period, right? If you're going to somebody who's not an obesity board certified or an endocrinologist, they may just concentrate on the number on the scale, right? And you come back a month later, you lost 20 pounds, that's fabulous, but you lost 6 pounds of muscle and your percentage body fat might have gone up, right? So if we base our success in the scale or in the BMI, we will be missing many things, including the possibility of causing or making the patient skinny fat, right? So many times, and I now that I have much more information on what is weight loss and how a complicated process it is, and it's not just dropping the number on the scale, I wonder how many people we made skinny fat, right? Just by concentrating on the number on the scale and being happy with because somebody lost 30 pounds in 1 month,
Sure.
when probably they lost muscle and their basic metabolic rate went even lower, their metabolism got worse. So we haven't been doing the proper things right.
Got it.
The weight loss drugs may be not new, but the way that we are evaluating how people is losing weight, that is new. And
Got
when you
it.
go with an obesity specialist, they're not just going to be happy that you're losing weight. They're going to make you strong, fit, having more muscle than body fat at the end of the journey, because that's health, that's longevity,
Yes.
having more muscle mass than body fat.
So there's a lot of risks that I hear, and I'm gonna ask you in a few minutes about just the people that are doing this for cosmetic reasons, like that last 5 pounds. Because I actually know people doing that, so I want to talk to you about that. But what about the risk like when you go off of this medication? Is that also based on provider? Because it's my understanding, and it helped me understand this because I might be explaining it totally wrong, that like Ozempic manipulates your insulin. It changes how and it changes your gastric emptying, like so it slows down the process. So if one, does it do those things? And two, what happens when you stop it, or do people have to be on it for the rest of their life?
So to answer that question, we have to go way back to the basic and what's obesity and what's overweight, right? Obesity and overweight are not a lifestyle problem. It's not the lack of exercise. It's not the lack of nutrition. It's part of it, right? But obesity and overweight is multifactorial. There's about five, if I put them broadly, factors that can contribute to weight gain and obesity. One is lifestyle, as we mentioned, right? The other one, which is probably 2/3 of the cause, is some genetic background, some hereditary, some family history, without necessarily being a genetic mutation. There's other cases of obesity that are more severe that they're detected in childhood, but just the regular person that doesn't have that, about 40% of their weight or obesity or weight determination is already genetically predisposed by your family history. Then we go to aging. It's another factor, right? As we age, our metabolism that slows down. Then we go with hormonal changes as a cause of obesity or weight gain, like in women, classical premenopause, menopause, the drop of estrogen. And then we go to environmental factors. Where we live, is it promote walking? Is it sedentarism? Do we work from home? The food industry, right? So do we sleep? Do we not sleep? And we live in an industrialized world that promotes obesity and weight gain. So it's multifactorial. So if we concentrate on the patient maintaining their weight loss only back to the basics, we're missing the whole point. All of this, all the other factors are going to promote the patient to regain the weight. Right? It's not the lifestyle that is going to maintain the weight loss. So that's why the medication are designed for chronic long-term use, because obesity is a chronic, multifactorial disease. We don't cure it, we control it.
That all makes sense to me. So now what doesn't make sense to me is the people using it to lose those 5 pounds. They'll lose the 10 pounds to microdose it, help me understand that, because, and I actually have some friends that did this, and it's interesting because they got like, they dialed it in and they looked, and then they stopped it and they gained it all back. And it's just, to me, I was like, what's the point of this? So can you speak into that?
So there's 2 points to make there that are really important. One is, what are we basing that estimation on? Right? Are we basing that estimation of those 5 pounds, 10 pounds on a BMI? On what, right? Because I've seen many patients that they may have a normal BMI and they have high percentage body fat, they have high visceral fat, that they will benefit from the medication, right? That's one. That by the simple eye, we cannot say who does and who doesn't need the medication, because they may look slim or thin or skinny because they don't have muscle mass, but not because they don't have body fat to lose. That's number one. And the second, the question that I can base that decision is, okay, you have 10 pounds to lose. What in your life is it costing you to be this weight and to try to achieve those 10 pounds extra, right? So does it become a full-time job for you? Is it taking most of your daytime thinking, planning, exercising? What extremes are you having to do 10 pounds or 5 pounds more? Those patients may benefit from the medication, right?
What about side effects for those people though? Because like I've definitely heard of like some gastric things, and then their
So the
insulin
side
changes.
effects are going to be the same for somebody who has to lose 100 pounds to somebody who has to lose 5 pounds, and it's going to be muscle loss, dehydration, right?
Wow.
And depending on the class of drug, there may be nausea, like with the older drugs, Ozempic. Now Ozempic, we're going to say it's almost older because we have newer drugs. But with the newer drugs, which I have to mention, tirzepatide, which is Mounjaro, Zepbound, we don't see nausea, we don't see constipation. So,
Really?
and this is the future of the weight loss medications, right? They're going to become more sophisticated, more effective, and safer.
Wow. So what is your prediction here? Because like we always, say in fat loss and in weight loss, there's no such thing as a magic pill. Like there's no such thing as a magic pill. And I teach it.
There's not, it's a magic injection.
Yeah. So that's what I want to ask you. Like, is this the magic injection? Like, do you think when you think of the future, do you think obesity will be gone? Like, what do you think
I'm
here?
going to tell you, I think that what we are witnessing right now is the biggest event in medicine that we've had probably, I don't know, in the history of medicine, because I would say this is even bigger than insulin, right? Because insulin was only for the patients that had type 1 diabetes.
Yeah.
This is for people that have obesity and overweight. And I mean, it's predicted that in 2030, almost 50% of the population is going to have obesity, right?
Yeah.
So I think that this is really going to change the way that we live. I think we're going to live longer and healthier lives. I think there's going to be less cancer, because there's many cancer produced and associated with obesity and the visceral fat, right? That it's an inflammatory tissue. I think the way that we practice medicine is going to change because of these medications. If you think about it, we've created specialties of specialties from obesity, for the complications of obesity,
Okay.
right? So I think we've been very comfortable because that's what we knew, and that's what we only had to
Yeah.
work with, was treating the complications of obesity, because we didn't have anything to treat the cause, right? So now we have what to prevent all those complications from.
So when I've heard that these are originally created for type 2 diabetes, is that, I mean, is this kind of go together, or what is it about the insulin that this helps with, that's why that was originally created with that?
So these medications, they target, in regards to weight loss, they target two reasons that we humans eat, right?
Okay.
In regards to diabetes, what it does, this medication, it's a hormone, it's a synthetic hormone. GLP
Okay.
incretins are hormones. What they do in the pancreas, when your sugar goes up in your blood after eating, as an example,
Uh-huh.
they work in your pancreas to produce more insulin. That's
Okay.
how it works for diabetes, right? So you're making more insulin, you're making your pancreas work better when your sugar is high. But if your sugar is normal, it's not high, it doesn't stimulate the pancreas. That's why we don't see hypoglycemia on these medications. That's
So
why we can use them in non-diabetics.
how is this different than like metformin? Because like metformin would reduce your blood sugar. So do they operate sort of similar?
Metformin, no. Metformin, what it does, it increases insulin sensitivity in the tissue.
Oh,
So it
okay.
helps your insulin that you're making work a little bit better, but it doesn't help your pancreas make more insulin. Otherwise, we would use it for type 1 diabetics, and we don't, right? We use it only for type 2. So it doesn't affect the pancreas. You don't make more insulin
Okay.
with metformin. It just makes the one that you're making work a little bit better in the tissues that is going to have an effect, like the muscle, the brain, the heart.
Right. So,
But in regards to weight loss, these
mhm,
drugs, because I think it's important that we explain how they work,
mhm.
and how they differentiate from bariatric surgery. So what they do, these drugs at your gut level, they increase your satiety hormones when you start
Okay.
eating, and they decrease your hunger hormones in between meals. So
Wow.
what it looks like is you get full with maybe half of what you normally would need to get
Okay.
full, and then you'll be full for 8 hours, and then you'll get hungry again, but then you'll feel full again. So you're content with a half of what you normally will
So
feel
it ends up
content.
being like somebody that actually doesn't have a weight issue, like how that person is typically eating or hungry. Is that
Exactly. It changes the behavior. It helps you know how to feel full again and eat when you're
yeah.
hungry, and not eat for just for eating. Then in the brain, in the amygdala, in the hedonistic eating and drinking area,
Hmm.
it takes away the anticipation of a reward towards certain food or alcohol, right?
Yeah.
So one thing is you feel hungry, you eat and you're satisfied. But another thing is that you're thinking, oh, I want to have this pasta. I want to have a glass of wine when I get home. You are anticipating a reward of that. So this medication takes it away. So you eat
Got
when
it.
you're hungry, you enjoy it, but
But
then it's out of your mind.
it sounds like too good to be true, like it almost sounds like, so help me with that. Cause there's a yin and a yang to everything. So like, I think about, well, first of all, I have actually seen people that didn't have a lot to lose do this and then go off it and have rebound effects. Like now they've got high blood sugar, they've got things going on. So what is the danger of this?
Well, the danger of this is that the people that are prescribing this drug, or whoever you're getting the prescription for, are not educating you about the drug,
Okay.
right? This drug does not replace a healthy lifestyle, does not replace
Mhm.
healthy eating, as healthy eating and a healthy lifestyle doesn't replace the effects of the medication,
Got it.
right? So they work good, they work better together. So you need somebody who's going to guide your lifestyle around this drug. It's
Yeah.
not like, here you go, I'll see you in 3 months and good luck. You
Right.
have to tailor their nutrition, tailor their physical activity, their exercise, their hydration.
So
It's
it's
a
not an excuse
complicated
to take
process.
this and eat everything. You're still doing all the things we're learning.
Exactly.
This is what
And
helps you eat it.
by the way, the few patients that don't lose weight with this drug is
Hmm.
because of that.
Got
Because
it.
their caloric density, even if it's a half a portion, it may have
Totally.
2,000 calories, will that we never catch up.
So
I know.
here's my struggle. I'm just being honest with you. I'm just going to be honest with you. So I've been fat loss expert for years, fitness, nutrition, and I teach this and I've helped people lose 100 pounds plus. I'm not you. I'm not a doctor. I don't do it that way. But in my mind, and I believe me, I get obesity is a very real genetic thing. There's a
Yeah,
lot going on there. I don't think people are lazy and that's why it's happened. I don't believe that at all. But I'm having a hard time with the quick fix mentality because I've always taught, let's do it. Let's
yeah,
change our relationship with food. Let's change our mindset. Let's do our movement. Let's use supplements. And so I'm struggling with that. And I'm also not naive. And if there's something that really could help people, because here's what I also look at. Even if
mm,
there's side effects, if this is going to also reduce your chances of cancer or type 2 diabetes complications or like all these other things that go with obesity, then what's the payoff? Like to me, I'm like,
yeah.
well, yes, there's a slight risk, but if this is really going to help with all those things, I'm torn. I'm just being honest with you. Like that's
Okay.
why I'm trying to understand
And
this.
yeah, and I think it's a great question, and I think it's really important to clarify that um, this is not a quick fix,
Hmm.
right? Again, when you go to the it's just I cannot like emphasize it so many times because my goal, and I'm going to talk about how I practice medicine and how we
Hmm.
should see these medications, is not a quick fix. It's not you losing 10 pounds in 2 weeks, right?
Yeah.
It's not getting you into that Met Gala dress. It
Yeah.
takes
So
time, right?
you don't take those. If somebody comes to you with that, you see through that.
No.
Yeah.
So let me tell you what my goal, and this is what body composition is so important, right?
Hmm.
Because I always tell patients the healthy weight loss is 1 to 2 pounds per week. Anything
Yes.
more
That's what
than
I
that,
say.
you're losing
Yeah.
muscle.
It's
You're losing
water and
muscle, right?
muscle. Yeah. You're
Exactly.
definitely.
So a person that has, and I have a patient that lost 170 pounds. That's the one
Wow.
that's lost the most. It's going to be a year and a half, right?
Yeah.
If you think
Of
about 2 pounds
course.
per week with ups and downs through. So it's not a quick fix.
Yeah.
And that patient right now is 170 pounds less and her body composition is higher muscle mass and lower percentage body fat. So it takes time, and you know that it takes time to get the patient through
Totally.
to that, right? The problem is when you go into this med spas or you're getting it online and you're
Yeah.
losing
That's
30 pounds
concerning.
in two
Yes.
weeks, then you're losing muscle and you're
And
dehydrated, right?
that's
So
why we're having the
that's the
problems.
problem. Yeah, that's the
Yeah.
problem. And those are the people that are going to have those side effects that we're listening. Why?
Right.
Because these medications were tested in control settings with supervision. So we mimic that in our office. I see patients every 6, 8, 10 weeks,
Yeah.
right? Just to make sure that they're tolerating, that they're safe, that they're losing what they need to lose and not muscle, right? But if you're seeing somebody telemedicine, they're not doing body compositions, they're not taking your history, when did you start struggling with weight, what is your relationship with food, then that's wrong.
That
That
makes
I do
sense.
not support that and I do
Okay.
not promote that.
And then in the biohacking space, I definitely see people microdosing this now. Have you heard much about that? Where they're taking like somebody that's already fit doing these microdoses of it.
I mean, I'm sure that, this is, unfortunately, there's going to be people that want to take advantage
Hmm.
of what's happening, right? I I do feel that it might have use in certain situations where patients are athletes, they're exercising 6 hours a day, they're eating super
Right.
healthy, but maybe their metabolism, maybe their genetic background is not allowing them. Can we use this to help them achieve that? Under the right supervision,
Sure. Maybe.
maybe, right?
Yeah.
Maybe. Again, it's per case basis. It's per
So
patient, per lifestyle basis.
not that anyone's asking, but here's my opinion on it now, based on talking to you. Mhm. I think if you've got like that 5 or 10 pounds and you're just trying to do this to fit in and be trendy or whatever, like forget it. I feel like you're risking, I think you're messing with the wrong things. But if you really are struggling, like you're saying with obesity, and you've truly gone through all of this, I can't relate to what that's like personally. So I can't blame people for wanting to correct their health there because it does, we know that obesity shortens your life.
But like, even with, and I respect your opinion, and we'll entitled of our opinion, but it's not like, oh, you're gonna lose 5 pounds, but you can maybe end up dead. No, that's not.
Right.
These
Okay. Got
medications
it.
they're very safe again when
Yeah.
they're used by somebody who used them
Yeah.
often and know. I
Would you do it on yourself? Like, would you do it on yourself for
Yeah.
this? You would? Because you
Yeah,
see
I
it enough.
actually,
You
first time I'm saying this, but I did it when after my
really?
second child, I gained, in my first pregnancy, I've always been, I exercise, fit.
Yeah.
Um, but after I had my kids late, I had my first one at 38 and the second at
Hmm.
39. This is my story. I was very restricted growing up in my
Okay.
20s and in my 30s, exercising 2 hours a day, 6 hours, 6 days of the week.
Yes.
I ate paleo. I didn't eat any carbs. I made my own flour with almond flour,
You did all the
coconut flour.
things. Yeah.
I was like a nut. I loved it and I felt great. But when I got pregnant with my first kid, it was like a switch. I was
Yeah.
like, oh, I'm allowed to do this. I can do this. If I'm
Right.
pregnant, I can have a cupcake. I can do this. And I gained 70 pounds.
Yeah.
Right. So then I got pregnant within 5 months of having my second baby. And then in that one, I was more controlled, but I was already carrying so many weights,
Totally.
right? And then I had my second one. So I ended up with 30 pounds that I couldn't lose. And
Okay.
I was a fit person. I knew what to do, but I was struggling. I was in my early 40s now.
Yeah.
I used the medication and I got to where I went back. And now I found a balance because I cannot spend 7 days, 6 days in the gym, 2 hours a
Yeah.
day, right?
Yeah.
It's just finding that balance.
That
But
makes sense.
having a very restrictive life is also,
Not
it's not
amazing.
good,
Yeah.
right? It's
Yeah.
not good.
Yeah, no, I hear it all. This is just all so interesting to me and so new. The reason I wanted to interview you is I don't want to withhold information. Like I want to share this. I want if this could
And
help somebody.
I think that goes for a lot of the personal trainers and the physical the training business, right? I
Hmm.
think I don't want them to be afraid. We're not going to take patients, and I think we need
Yeah.
you more than
Oh,
ever.
I think it
Like
works together. It works,
I
like you said,
never
they'd have to learn
refer
the lifestyle.
I've
Yeah.
never referred so many patients to physical trainers, personal
Yeah.
trainers, as I do now with the weight loss
Yeah.
medications. Because I want to prevent the muscle
Of
loss. I need
course.
I need a personal trainer, a lifestyle coach to help them
Yeah.
maintain their muscle, their nutrition habits. It's like I feel like we need each other more than ever for the
Totally.
goal of the patient.
I'm with you on this. No, this is fascinating to me. What I'm hearing through all this too is a big red flag warning about where you're getting this done and who is
A
doing
a
this for
hundred
you.
percent.
Because I
I
do
think you
see
have
the
to.
med spas and all the random like that's what scares me too.
And then you get the compounded medication that all the obesity societies, the endocrine society, the bariatric society, they came with a statement probably like 2 months ago, of all advising against compounded medications because they're all the side effects and bad things that we're seeing is from
Hmm.
not regulated, right? The
Hmm.
compounded medication. And usually those compounders are sold in the med spas and they sell it per
Yes.
syringe. So then we go into that not properly supervised, regulated service.
Got it. Okay, makes sense. Yeah, I use compounded bioidentical hormones. So I hope they don't shut down compounding, but I hear you on the
No,
on
for
this.
semaglutide, it was for semaglutide, specifically
Okay.
for
Yeah,
semaglutide.
for so gosh, there's so many names. So semaglutide, Ozempic, are they just all different versions of this, or how do
Yeah.
we know?
So semaglutide is a drug, right?
Okay.
Semaglutide is a molecule. Ozempic is the branded semaglutide for type 2 diabetes.
Oh, okay.
Wegovy is branded semaglutide for weight loss. And then we have tirzepatide, which is our newer of the bunch. I like to say is the iPhone 15 of the class of the drugs. And that's Mounjaro and Zepbound, which is the same drug, same
Got
pharmaceutical.
it. Okay. No, this is fascinating. Thank you so much. This was super helpful.
No, you're
Where can
very
people,
welcome.
if people are going to, can people work with you from all over the country, or how does that
Yes,
work?
I
Okay.
do. I do telemedicine. I have international patients. I'm based in New York City. My office is on Park Avenue in New York
Okay.
City, but I do telemedicine.
Amazing. I'm going to link all of your information. Thank you so much.